Ai, nani saa hajui ni wewe tu.
Vous allez bien?
Oui.
Hello. Audio test. So with me, the teams that are going to facilitate this afternoon session, they are going to introduce themselves to you very quickly. I'll start from the immediate left and go clockwise. Dr. Dhabangi can start.
Afternoon, viewers and fellow panelists. Aggrey Dhabangi is my name.
I am both a pediatrician and a transfusion medicine physician. My host institution is Makerere University in Kampala. I also do some work with the Uganda Blood Transfusion Services.
Good afternoon, everyone. My name is Sarah Myanja. I'm a senior nursing officer working with Uganda Blood Transfusion Service. I majorly work in the quality department, which develops, implements, and monitors quality standards, monitors and reviews quality standards within UBTS and other health facilities.
Good afternoon, everyone. I am Dr. Harry Chen. I am an emergency physician and an educator with Seed Global Health at Makerere University.
Thank you, Dr. Harris. Okay, clockwise.
Thank you very much, moderator. My name is Brian Agaba, Dr. Brian Agaba. I work with Seed Global Health as a clinical advisor. And I would like to thank you all for tuning in every 2 weeks for this very important CPD opportunity. And on that note, I'd like to inform our dear participants that the Uganda National Midwives and Nurses Council has accredited us to start offering CPD points. And this is going to be upcoming in a few days. So all nurses and midwives that tune on, you'll be able to receive CPD points from this session. Thank you. Over to you, moderator.
Next slide. Is everyone hearing us online? I think yes, because we should have, yes.
Yes, good afternoon, everyone. My name is Dr. Joshua Ogwang. I'm a medical doctor by profession, a medical officer. I work with Princeton Children's Hospital, Kololo. And today I'll be your guest presenter, and I welcome each and every one of you to this session. Thank you very much.
Thank you very much. And we are now heading on to another very important activity. In emergency care and emergency operations, we behave like Rotarians. And for that matter, I am a Rotarian, a fellowship from Lakeview in Mbarara. So there is a pre-test that is going to be posted on your screen, and would love that you quickly go through each of the questions. There are about 4 questions. Look through critically and give us your mind into the presentation, such that we are able to see knowledge in and out at the end of the presentation. So far on my screen, I can access the pre-test. Question 1 and 2 are visible. You can answer question 1 and scroll upwards, and then you'll see the question 2 is also visible. As I'm talking, people should be already doing. I'm trying to give you a preamble to how to go through the navigation on your screens. So you scroll upwards and you'll see the objectives or the responses. It can only be 1 response for each question until you are told to have other responses, but I'm sure we set 1 response for each question. And it will take us 3 minutes, but we want to be quick. So as you are answering, I wish to bring to your notice that today's session is a very critical one. And most people imagine it is other people who ever need blood, but it can always be any one of us requiring blood. And in ECHO, considering the orientation and the design of the program, transfusion is one of the critical services that are required in the country, but largely missed by majority at critical points. If you recall, during COVID emergencies, most people who had blood coagulability profiles deranged, they required blood and blood was not there. And the reason blood transfusion was advancing is people being in school, being in lockdown, and so many other. But so moderator, you can move question 2. Co-moderator, okay. Scroll upwards, and we are counting. When the 3 minutes end, we shall stop. So as an epidemiologist, I wanted to give you a clue on requirement and the burden of transfusion services. And according to Uganda Blood Transfusion Services, it is estimated that about 340,000 units are collected per year. And of these, only 240,000 units are realized. So the estimate is 340. They can only raise 240 per year. And you realize when you look at the police profiling of cases of accidents, majority of the people require transfusions. Majority of the mothers, when you look at the profiles of DHS2 data, most of the mortalities occur as a result of hemorrhage or blood loss during labor or during pregnancy or pregnancy complications. And to some extent, there are people who need to be transfused, but they still have cultural beliefs, they have cultural tendencies or other beliefs that they advance to ensure that they avoid the transfusion service. I personally experienced one person, and I culturally had to divert from them until I convinced them that it's their life, not the culture of their people. And I had to transfuse them from theater. So the whole day they were in theater getting BTF. But I was telling them that this is your life, not the life of the people around you. So you choose if you want to die or die. So the safety and the quality of blood transfusion should be part of the things we need to tell the members, and the knowledge on transfusion and the criticability of the service and what it actually does, because people need to understand that for us to survive, we need oxygen carrying molecules, and that is the hemoglobin that is within blood, nowhere else, not in food and not in water. By the time you begin requiring transfusion, it's not expected that you have starved and you are terrified. So it's always a critical service. So some of these challenges will help us to understand them and how to go over them. And I expect the main presenter on anaphylaxis to kindly get into the transfusion reactions such that people understand them very, very, very well. And with this, we expect that as an outcome, transfusion services should be a smooth experience in facilities and to people who require the service for the survival and the elimination of the critical states that we normally encounter with such patients. I think our time for the pretest is over, so I wish to call the main presenter, the case presenter, Dr. Ogwang Joshua, who works with Princeton. It is Prince then Don. So Princeton Children's Hospital in Kololo to take us through the case presentation. Over to you, Joshua.
Yes, thank you very much, Mr. Papuru. Once again, my name is Dr. Joshua Ogwang, medical officer with Princeton Children's Hospital, Kololo. And today I'm going to give us a case presentation of an anaphylaxis reaction. And particularly it's not a transfusion, but reaction, but however, all these reactions follow the same pattern and mechanism of activation and treatment are more or less the same in terms of principles. So today I'm presenting to you a case of a 7-year-old girl. She's a known asthmatic, a referral from a peripheral clinic who presented with a sudden onset of high fever that was measured to be 39.1 degrees centigrade after receiving intravenous administration of Ceftriaxone by a trained nurse. Her mother observed that she had developed a bit of a pruritic erythematous rash just within 15 to 30 minutes, approximately, that's what they say, after receiving the drug. So on arrival at the emergency room, so from there they shifted from the clinic and moved into the hospital when we received them. So on arrival in the emergency room, she was still conscious, though severely distressed, irritable with stridor, swelling of the eyes, the lips, and the eyelid. There was widespread urticaria. So when we examined, she had respiratory distress. It was a bit severe, and I would say near choking, probably due to edema of the airway. She had a tachycardia of 160 beats per minute and a 3D pulse. The decrease, there was a sharp decrease in blood pressure. It was at 78 out of 40 millimeters of mercury, and the SpO2 was 80%. She was on oxygen, nasoprang, and she arrived with us. So we examined the airway, and immediately we noticed that as we handled the situation, it could escalate to something that would need intubation. So we made a distress call to city ambulance because they're equipped with ambulatory vent machine that could rescue us. So in the meanwhile, we had to intervene as we waited for the ambulance to come in and also possible intubation to secure the airway. So we had a continuous pulse oximetry monitoring revealed that SpO2 had dropped now from 80 to 42, and on auscultation, HS revealed bilateral wheezing. In the emergency response, we gave in 2 doses of epinephrine, 0.5 milligrams, and we also gave intravenous hydrocortisone 100 milligrams. We were given in oxygen that was aerosolized with salbutamol 2.5 milligrams and budesonide 0.25 milligrams as we were administering the oxygen in order to secure or make sure that the bronchospasms was cut down. So we noted the slow response and a bit of a rapid deterioration in the clinical status. We were noting that the chest was becoming a bit of a silent one. So in that response, we immediately made a sharp decision to escalate the treatment. We gave in IV aminophylline and a slow infusion, a 20 ml syringe. We had put there 200 milligrams in 10% of dextrose. And we gave this over 2 minutes. Remarkably, we had quite a good improvement within that because the situation had escalated. And we had a bit of a relief in the breathing, the difficulty resolved, however, with some mild stridor remained, and the SpO2 increased. So the patient responded to this management, and within a short while, our blood pressure had risen back up to 106 out of 52, and the stridor resolved. And about 1 minute later, but the pulse remained quite high. So the parents indicated that they were not sure whether the patient had ever been treated with Ceftriaxone before, and she had never experienced any adverse drug reaction to medication. But our doctors say she occasionally had wheezing, mild wheezing whenever she visited the doctors or when she contracted cough and flu. So over the next 15 minutes after the administration of aminophylline, the severe clinical symptoms had resolved, and we were having SpO2 standing at 94% in room air and 99% on oxygen by nasoprongs. And the BP was now stable around 114 out of 71, and the pulse rate was still 117. The respiratory rate was now 20 cycles per minute, and we are only having a bit of a mild occasional wheeze that was showing up. So the situation was calm, and the distress call to the ambulance was cancelled, and we continued with the management. So in our ABC response to the situation in the airway and C-spine, we could note that in the examination part of it, that we had obvious respiratory distress. She was able to speak 1 or 2 or 3 words, but with a stop and a break. And when it opened up, we noticed that the airway was a bit edematized. So we made a bit of a jaw thrust as we gave in the oxygen, and then also we made a distress call. And the breathing part of it, in the emergencies before the calm of the situation, our respiratory rate was 36 cycles per minute. SpO2 was 48 in room here, but when you gave in oxygen, it would reach 80 on non-breather. And then the chest expansion was symmetrical, but we had a prolonged expiration with bilateral wheezing on both sides. We had fine crepitation bilaterally with a dull percussion node. So down there, I've noted that later we noted more of a silent chest and gasping that prompted us to escalate how we're managing the treating the child. So in that response, like I said, we gave in oxygen therapy together with nebulized salbutamol, 2.5 plus budesonide 0.25 at together with oxygen at 10 mils per minute, and SpO2 noted some good improvement. We also gave IM epinephrine 0.5 milligrams, about 5 minutes apart. We gave 2 doses before we escalated to IV aminophylline. So in the circulation part, we had a bit of cold extremities. There was no pallor, and the tachycardia of 160 beats per minute with a steady pulse and a blood pressure of 78 out of 40. The capillary fill was 2 to 3 seconds. And in that response, in addition to the drugs we gave, we infused over 750 mils of normal saline within a span of around 30 minutes. And the disability end of it, the child was still conscious, but just confused, agitated, and anxious. And the pupils were reactive, were equal, and all reactive to light. There is a soft neck. The power was 5 out of 5 in all limbs with a normal tone. However, we had a bit of uncoordinated movement and grasp due to the confused status. And then we had an intact sensation. So we just gave her a bit of a bed rest as we continued with the intervention. Next. So on the exposure, we did not have any observable open injury. And we can proceed to the next slide. So, and part of now the end of the history taking, we used just using the sample, the ample mnemonic. So we noted that in the history that she had a bit of a cold allergy, and she was a bit allergic to cold and dust. And then she was also an asthmatic, non-asthmatic child. And the medications that was given, she was started on IV Ceftriaxone about 30 minutes prior to this event. We couldn't identify the specific brand. And she was also a non-asthmatic who was in maintenance of Montelukast 5 milligrams. And she was using a Ventolin inhaler whenever it's needed. So in the past medical history, she was a non-asthmatic. She would receive around 1 to 2 mild attacks per month that could resolve with the Ventolin inhaler. And the last meal was about breakfast she had eaten around 4 hours ago. In the events that was preceding this, she was administered IV Ceftriaxone about 30 minutes ago prior to arriving at our facility. So in the problem list that we had to deal with immediately, we had a bit of the lung congestion, circulatory collapse because of the low blood pressure that we were experiencing and the cold feet. We had severe bronchospasms that was completely almost being obstructing the airway and getting us a silent chest. So we had to escalate, and then we had airway edema. So in the follow-up, this is the follow-up, what happened to her in the end. So she resolved with the treatment that we gave in eventually. So we observed her for one day, and after she stabilized, she was discharged home. In the meanwhile, we changed our antibiotic to IV Flucamox, and we noted that we should at least try to keep away from the Ceftriaxone for now on all the cephalosporins in general, and she was alerted to always inform our parents and any doctor was going to treat her. So we continued with IV Ceftriaxone, 12-hour IV hydrocortisone, I meant to say, 12-hourly for the next 2 days. And then just notably, she had about 3 episodes of loose motions in about a span of 1 hour. Then after that, it resolved. And we also canceled our distress call to the ambulance. So generally, our patient was discharged home, strong and happy. Thank you very much.
Okay, thank you so much, Dr. Joshua.
Thank you.
I now call to the attention of the audience to respond to the case and how it has gone. So as a guide, we would want you to respond in a way that you react in a way that you tell us what was done well? What do you think should have been done, and what are the areas of improvement for Prince Septon Health Center? I personally realized after 1 hour is when the distress call arrived. Yet from the start of the case management, you press the call to the ambulance, but until the distress call was pressed, you had already almost struggled your own way. But in emergency operations, that is expected. You continue working until when the other assistance arrives to you. But I would personally want to understand what the challenge was, that the ambulance was not there, or you called when they were already parked in front of the clinic, but you are still stabilizing. So we need to understand the challenges with the transport mechanism around here.
So when they came in under a border or a motorcycle, precisely said. And when immediately we admitted and noticed that the airway was edematous and we could potentially need intubation if the situation escalated, we made a distress call. The distress call, at first attempt, within the first 5 minutes, we couldn't get a hold of the call, but our call was received and the response was being made. But in the meanwhile, when the response was being made, within 5 minutes, around there, when we had just made the call, the situation escalated and we also had to act promptly. Fortunately, the treatment or the response that we gave also gave us the resolution. Whether later on, when we realized that the situation had resolved, we canceled the distress call, but they were responding.
Thank you for that response. And in an operation like that, it is very good that you communicate to the relatives and never to show them that you are such distressed and unable to proceed or you are panicking. Thanks for keeping calm. But any hands up there? I can see the hand of Gillian Park.
Yes. Good morning.
Unmute yourself.
I've tuned in from London. Thank you very much for the excellent presentation, which I enjoyed. I like the comment that you made that the situation remained calm during the management of this child, because I'm sure it must have been a very frightening situation for many. My only comment would be that in UK practice, for a 7-year-old child, we would actually use a smaller dose of IM adrenaline. So we use 0.01 mLs per kilogram. For a 7-year-old, it usually works out as 0.3 milligrams, 300 micrograms, rather than the 500 micrograms that you actually gave. I just put that into the picture, that the anaphylaxis treatment for a 7-year-old should have a slightly lower dose of adrenaline. I don't know if anyone else would like to comment on that, but thank you very much for your excellent presentation.
Thank you so much for your concern. And I want you to understand very critically that this is Kampala and Uganda at large. This child actually presented in Kololo, a health facility privately owned, just 2 kilometers away from the National Referral Hospital. So you'd imagine what was going in the mind of the attendants or the relatives and Dr. Dhabangi's referral unit. So Dr. Dhabangi is one of the people around who takes charge into additions into what national management guidelines can be, and they circulate to referral peripheral units, and we use Uganda clinical guidelines. So as much as possible, the country health team and emergency responses are guided by the UCG inputs and the tools actually and facility strength to have the items to utilize in such an instance. Some areas lack even basics of a pulsoximetry or what. So Dr. Dhabangi, do you want to have a comment into Gillian's input very quickly?
Yeah, I think I do agree with Gillian. The dose for a child is a little bit high that was administered, but besides the dosing, even the route of drug administration. I'm not an emergency pediatrician, but I would favor the intravenous route. You know, epinephrine is something that you can give in many routes. But in such an emergency, you want to go intravenous. Intramuscular was really maybe not the very best. Yeah, in my opinion. Over to you, moderator.
Thank you. Thank you. Intravenous when they were struggling with whatever is available.
Yeah, and the other thing also why maybe sometimes dosing really challenge most health workers, the approach is to dilute it. So once you have the vial of epinephrine, then you try to give to these small, human beings. The best thing is try to dilute it. Then you can actually dose appropriately according to what we have discussed.
Okay, thank you. I'm also Businj. I think this is also to your question has been understood that the dosing had an issue, but the ability. I just credit their unit. They were able to do the evaluation and observation of their intervention. So nonetheless, the child was safe.
We've lost the sound.
You unmute.
Well, we can't hear you here. Just do us a favor and unmute.
Could there be somebody with admin rights to mute people whose mics are open? Thank you.
I'm not getting the network. I think is not clear.
It is not the network. The microphone is mute. The thing is unmute, and then we hear what they are saying.
Dear presenter, we are not hearing. Please unmute your microphone.
Can you hear me now? I'm on mute here.
Better.
Can you hear me now?
Yes, better. We can hear now.
Yes, we can hear now.
Okay, so as I said, this was a classic case of anaphylaxis, a life-threatening condition, secondary to a parenteral antibiotic. It was handled aggressively with intramuscular adrenaline, which is the drug least listed in most of the guidelines. The dose, certainly the comment about the high dose is well taken, but this aggressive treatment, both with the adrenaline and then the adjunctive drugs, really did save this young gal's life.
Okay, thank you. So we've got to be very careful in emergencies, but thank God the team remained calm until the child's life was saved. I'm happy that whoever brought the cases to the unit went away.
So we can move to the next item on the schedule, and we still request Dr. Harry to
to take us through the assessment and investigation and management of anaphylaxis. So over to you, Dr. Harry. Are we still having issues with the audio team? Are you listening to us?
Yeah,
We
perfect.
can hear you.
Okay, all right.
Clear.
So I'm gonna go ahead.
Clear.
If people could mute, I'm gonna go ahead and make a short presentation about anaphylaxis and hypersensitivity. Next slide. So I think, as I mentioned, anaphylaxis is a potentially life-threatening allergic reaction. It's important for all clinicians to recognize it based on the sudden onset and rapid progression, as we saw in the 7-year-old, the airway, breathing, and circulatory problems that this child demonstrated, and the skin changes that really are sometimes the hallmark of this condition. The diagnosis is supported by exposure to a known allergen. This one, we did not know it, the cephalosporin to be an allergen, but we did obviously see the direct result. And that we need to treat and approach this as a life-threatening feature using the ABCDE approach. Adrenaline, as I mentioned, is really the mainstay of treatment for anaphylaxis, and that's where we should start, and we'll talk more about what we can do next. Next slide. So briefly, I'm just going to show this up for an example. You know, there are a lot of hypersensitivity reactions or allergic reactions, and they vary from type 1, which is what we just saw, anaphylaxis, which is caused by IgE-mediated mast cell degranulation, happens quickly and can be life-threatening. And that spectrum really varies all the way to type 4, which can take days to weeks, with a rash, something like Stevens-Johnson syndrome. But there are many kinds. We're going to focus mostly on type 1 or anaphylaxis. So in this, our approach really needs to be, as we always do, with the ABCDE. And so you need to look at the airway, which can oftentimes be hoarse and stridorous, which we saw in this young patient. The B with the increased work of breathing, wheezing and cyanosis and hypoxia. And the C with low blood pressure, signs of shock and reduced consciousness, which goes right to the D. Don't forget the history because it's the history that will tell you if there's been exposure to a known allergen in the patient. These are just a picture of some of the skin manifestations of anaphylaxis. Angioedema, which apparently was the case in this young child, which is swelling of the face and the airway, and then the urticaria, the classic hive or urticaria rash that is so commonly seen in anaphylaxis. There are lots of different manifestations, and everyone can have copies of these slides, and we can see that they include upper respiratory problems, cardiovascular problems, skin problems, respiratory problems, and digestive problems, which interestingly enough, we did see in this young child when they had several bowel movements. The diagnosis of anaphylaxis, there's many different criteria. This is just one of them from the World Allergy Association, but really it comes down to what we saw in this patient. Acute onset of an illness very quickly with skin changes like hives, and at least one of the following. She had the respiratory compromise, she had the low blood pressure, and she later developed the GI symptoms with the crampy and the diarrhea. But also, either could also have just hypotension and bronchospasm or laryngeal involvement without the absence of any typical skin involvement. But you can see all the things that are necessary to make this diagnosis. This is another from the United Kingdom, which is anaphylaxis. It's clinical diagnosis. There's no blood test. There's no lab test that will tell us that this person has anaphylaxis, and there's no time to really waste treating the patient. So it's a sudden onset, rapid progression of symptoms, airway, breathing, circulation problems, and then the skin problems that we mentioned that might be obvious, but can also be absent in some of the cases. And we can also see the GI symptoms that we mentioned, abdominal pain, vomiting, and diarrhea.
There is a spectrum of disease, starting with mild symptoms, just a rash, which may not be anaphylaxis if there's no ABC problems, all the way up to severe anaphylaxis, like we saw in this particular case, with hypotension, confusion, with airway and breathing. What usually precipitates anaphylaxis really depends. A lot of it is geographical, but this is an example from the World Allergy Foundation: food, cow's milk, eggs, peanuts, shellfish, insect venoms. In the West, most common cause is probably, one of the more common causes are bee stings and wasp venom, and then drugs, as we saw in this particular case, can oftentimes be what's inciting the anaphylaxis. There are different mechanisms for the different allergens. They can be related to immunologic mechanisms. They can be immunologically independent, like with some contrast agents. And there are different kinds of triggers and different kinds of mechanisms, but the end result is the same. You have the symptoms, you make a clinical diagnosis, and you go ahead to treatment. As you can see, anaphylaxis can be a fatal disease, and the fatal diseases, the quickest fatalities tend to be in drug-induced cases, again, injected drugs rather than oral drugs, and then later on we see stings, and then finally foods. So all of them can lead to fatal anaphylaxis, but it's the injected drugs that tend to lead it to the quickest episodes of fatal anaphylaxis. The hospital admissions and fatalities really depend on the age group. In the young age group, we tend to see foods, which tend to trail off, then to be replaced actually by iatrogenic or drugs, causing being the more common cause of anaphylaxis. This is a UK study. So once you make this diagnosis, it's important to know a little bit about your patient, and all I can say is, obviously, this is a patient that had a comorbidity of asthma, so this will complicate things. Cardiovascular disease also complicates anaphylaxis. There's something about giving adrenaline to an older person with high blood pressure and maybe heart disease, but it actually will still save their life. And then finally, beta blockers tend to be something which makes individuals resistant to the effects of adrenaline. So be aware of that, and if you have somebody who's resistant to your adrenaline, find out if they're taking beta blockers, and if they are, that's an indication to use a drug called glucagon. This is basically the British guideline for anaphylaxis. It's the diagnosis that we talked about, calling for help, which was done in this case in terms of calling for the ambulance, removing the trigger. So if there's an infusion of something going on that they're reacting to, stop that infusion or get them away from that allergen. Give that IM adrenaline, establish your airway, and then repeat it every 5 minutes as necessary. And in terms of adrenaline, the dose, as mentioned, is weight dependent. So teenagers and adults get 0.5 IM of 1 to 1,000. Children age 6 to 12 get 0.3. Children age 1 to 5 get 0.15. And as you can see, infants get a dose that is created per kilogram. Again, this is 1 to 1,000 adrenaline, the ones that are in the little ampules, which is different than what you might give IV. And I'll talk about it briefly. So that's the dose, repeat it every 5 minutes for at least 2 to 3 doses. And if it still persists, you're really dealing with refractory anaphylaxis. So here are the 2 types of adrenaline that you can find. One of them is what we commonly use, the 1 to 1,000. And they're actually calling it now the 1 milligram per ml adrenaline because of the confusion, versus the 1 milligram per 10 ml on the left, which is the intravenous formulation. You could always dilute it to make it, to change the 1 to 1,000 to the 1 to 10,000. The adjunctive therapy for anaphylaxis includes beta agonists. We saw this used in this case by Dr. Joshua, corticosteroids, You can use histamine blockers, H1 and H2 blockers, and glucagon for refractory cases with beta blockers. And then the British guidelines also mention aminophylline, which was used in this case. A drug that everyone seems to like to use. We don't have many uses for it now, but this is certainly one instance where it made some sense to use it. Refractory anaphylaxis is if they don't respond to IV fluids, adrenaline ×2, and oxygen. You can consider using further adjunctive therapies as discussed, and also the use of an adrenaline drip, which would be intravenously administered. And these are just an example of how you can mix adrenaline drip. You can mix it in a Volutrol, 1 milligram and 100 cc's, or you can mix it in a bag itself of 500 cc's of normal saline, and then titrate the drip, obviously toward what the effect is you want. And then, as mentioned by one of our presenters, you can use adrenaline as an IV bolus. And certainly it needs to be, if it's given in roughly the same doses, but also diluted. So you can't give the 1 to 1,000, you have to give the 1 to 10,000 if you are going to use IV adrenaline. The disposition, in this case, you can, as was with this child, if the patient gets well quickly, you certainly can consider observing them and discharging them. But obviously, if the more severe the case, the more adrenaline you needed, the more likely you want to admit them and observe them over the next 24 to 48 hours. So right now we're seeing something happen, at least very commonly in the West. So for instance, this child, theoretically, if they were at risk for having further episodes, it's episodes at home, you could do an EpiPen, which is really an at-home dose of adrenaline, as demonstrated in this picture. You could have adult doses, which is 0.3 milligrams, or child doses, which is 0.15 milligrams. And that's what we're seeing a lot of these days. So in summary, anaphylaxis poses a serious threat to life, as we saw in this 7-year-old. Prompt recognition and treatment is vital with the ABCDE approach. IM adrenaline is key to treatment. Most patients will respond to 1 dose of adrenaline, very few need 2 or more. You can follow the algorithm that I've included in this or in the references. And if they're refractory, you can treat them further with adjunctive therapy and or an IV adrenaline drip. And remember that these patients need follow-up to determine what it was that they were allergic to and potentially whether they need at-home treatment to or further treatment to desensitize them. And those are my references. Thank you.
Thank you, our senior trainer, consultant trainer. You've been here for these trainings, I think, over time, and we don't take it for granted for your rich experience that you always are willing to share. And I'm sure your products appreciate this input. I see most of our audience people are requesting for the slides. It's obvious that once you log in, we already have the email from the one that you used to log in, because that's why the link was posted, and the same slides will be posted to you. So kindly concentrate, and the slides will be shared to you. But you want the slides more than the facilitation, or you want to read them later on as a reference point? Just concentrate and learn from the experts here. But yes, thank you so much again, Dr. Hari. What we want to caution most of our audience people is that it's not good to read during the emergency period. You should do reading earlier. And in such a thing, if you have to read, the items should be in near, which maybe it's on the wall, and you could quickly flash your eye there, just somehow, and you just look at, or you should have your guideline there, and you should actually know the page number for most of these clinical guidelines that are always saturated. But if you are to show the attendants that you are now reading at this time, they will be very worried whether they have gone to a safe place. And the preparedness is always important. So at this point, we needed to have seen Dr. Joshua. Maybe he avoided it not to congest the slide, but we need an emergency preparedness plan for anything. As long as we set ourselves to be a health facility unit, we need everything in our resource to be available. So an emergency drug cupboard should have been available, such that people do not just run to stores, to inventory managers and start emergency purchases, especially in private facilities, when they expect nothing to be abnormal. Yet it is always an emergency. So even with these IV medications, people need to have emergency medicines with them along those trolleys or part of the preparation. Not already prepared, but at least in easy reach. It could be on your kidney dish as you are preparing your Ceftriaxone or your other any medication. Expect anything to occur, because anaphylaxis can be from any source, external or internal. And most of the interventions they are giving while cases are with us, they are external. The body is already reacting to some stressors or anything foreign, and we're also introducing other foreign agents. So anything happens to it because the immune system, as you saw, the T cell and cell mediated, it can be very, very fatal, and you don't know what internally the body is fighting with. It would be an accentuation that even what we are providing in is causing us a lot of trouble. So we would want now move to a specific precocious intervention, which is blood and blood products. And I want to call to, if there are any no questions on the forum to respond to, but we will respond to all of them, but we can put them in a pool and capture them, and we are responding to all of them during the plenary. So, Madam Sarah, you're welcome to present to us blood donation, management of blood products, blood and blood products. Sarah, as already mentioned to you, is a quality assurance manager. So anything to do with blood and blood products that has been of low quality or suspicious material, please ask Sarah today, such that in our peripheral areas, we do not get challenges of detected when we want to intervene right away, when it is. Thank you, Sarah, and you are welcome.
I'm not sure what you want me to do. Just go ahead and do it.
Thank you, Vivek. You're next.
So we acknowledge the Makerere residents who are having an emergency. They are having an emergency medical management course, training at a golf course. I would want to call their team lead to say aye, and maybe wave to us if they are on forum listening, if they haven't logged.
Emergency medicine.
Wow. It is emergency what?
Chair.
Emergency chair. Come next to the audio and say hi to us, and we can give you a minute to tell us what you expect as the outcome of that activity.
Good afternoon, participants. As you can see, this is a group of residents from Makerere University and Mbarara University, and they are currently undergoing a basic emergency care course. They are meant to be the trainers who will be coming to the different sites, and they will do a basic emergency care course across the country. So I have with me a team of residents in anesthesia and emergency medicine. So team, you can just wave to the people online.
My physical team, doctor, these are your residents. They will come to rescue you. Thank you, and we appreciate your involvement there. And we expect that you go into most of these places to save the situation of the tension. There's a lot of tension in these peripheral units, especially when it comes to their accreditation, and they do not have teams that have accreditation certificates to manage or having proof that you have attended ABS, basic life support and acute. So that's a very good input. So when you are pulling people into training, don't limit yourselves to Mbarara and Makerere. Go to Guru, Aru, and wherever. And yes, Sarah, you can take on the floor.
Thank you very much, Glet. My name once again, I am called Sarah Myanja from Uganda Blood Transfusion Service. Glet has referred to me as a quality assurance manager, but I'm not one. I am a quality assurance nurse. I have my quality assurance manager. She had traveled to Sweden and she's in some kind of a jet lag. She would be glad to be here with us. She has sent you greetings. So are you able to hear me? Thank you. So our training expectations today are going to be blood donation types, who is eligible to donate, the blood donor's role in improving the donation experience, then what are the screening tests done at UBTS, the products available in Uganda, their storage and expiry, the location of blood banks across the country, and then some bit of advocacy for blood donation as a clinician's role. Oh, sorry. So I'll take you briefly through the definition of the blood donation. Blood donation is the voluntary act of giving blood to save the lives of another person who is either known or unknown to you. It could be a relative, it could be a friend, it could be a nobody, or someone that you do not know. So we have the different types of donation. Here we have whole blood donation, where we get all the blood from you and then develop it or process it into components or blood products. Then we have apheresis donations, where we take some part of or some portion of blood from you, or we have like plasma apheresis, whereby we take off plasma from you using a machine. We have red cell donation. Here we take out red cells, and then platelet apheresis, where we take off the platelets only. So this one has been rolled out in Uganda. Currently, we have one machine. It was rolled out at the Uganda Cancer Institute in February, and we hope to use it at Nakasero anytime soon. Currently, it is doing what we call therapeutic donation, whereby we take off blood that is not needed or blood that we don't use in our health facility. Assist those patients who have excess. So what to expect from the blood donation? Before the donation procedure, you are encouraged to read our donor information material whenever you attend, to understand what is expected, what to expect, the importance of complete honesty and accuracy, and to make an informed decision. We ask you to complete a donor questionnaire. Then potential donors also undergo a medical examination, which is physical. And the physical examination, we do the vitals, that is the weight, we do the blood pressure, the pulse rate, and then the temperature examination. Then we also do what we call the hemoglobin estimation to understand how much blood you have. Then most importantly, we do consent the donors after they have made, this is to enable us understand that the person has made an informed decision to donate blood. Now, because safety is at the forefront of everything we do at UBTS, before everyone donates, they must follow a certain eligibility requirement because not everyone can donate blood. And these are the following. So first of all, we look at your health. One must be in good health at the time they donate blood. And question 1 of our questionnaire highlights this. We ask you, are you feeling well today? And when you say yes, we go ahead. If we don't say yes, if you say no, we don't proceed. We let you go until when you feel you're okay to come and donate. You must not be on any medication. You must have a hemoglobin of 12.5 for women, and for men, 13.5 and above. The normal pressure, you must have a normal blood pressure. The diastolic should be 90 and above. Then the systolic should be 140. If I go wrong, please, doctor, assist me here, but I hope I'm right. The temperature should be also 37 plus or minus 5, and the heart rate should be 60 to 90. Previous donations, we look at them. If a woman has donated if a man, the man who is able to donate should have at least taken 3 months after the previous donation, and for a woman, she should have taken 4 months. Then we look at the age as one of the eligibility requirements, and the age should be between 17 to 60 years old. And if you are a regular donor, someone who has donated at least 3 times in 1 year, and then subsequently donate for the following years, we allow you to donate up to the age of 65 years. Then the weight is a very important thing in our day-to-day work. We make sure that we take off blood from all those people or persons who are above 50 kilograms. We also look at the habits, traditions, and occupations. For example, someone who has undergone a needle treatment for less than 6 months, we don't take off that blood. That person should have at least taken 6 months and then done some tests to enable us to take off that blood. Then alcoholism and alcohol intake, these are 2 different things that we also look at. Alcoholism is the dependency on alcohol. Someone is on alcohol, smelling alcohol throughout the day or throughout the week and throughout the year. So such a person is deferred permanently. They are not eligible to donate. Someone who has taken alcohol, at least we wait for the last 12 hours and we allow that person to donate. There are those people who do bloodletting. We don't allow them to donate until when we are sure that they are able to donate. Someone who has injected recreational drugs, we also have a specific time that we've put in our selection criteria to enable them to donate after that. Male circumcision, if it is done in hospital, we give them time until when they heal fully. Then for the genital mutilation, the female genital mutilation, we go up to 6 months. The same applies to body piercings and tattoos. Then we look at the sexual behavior, and these are the people, those people at risk. We don't allow them to donate, especially those who practice homosexuality, multiple, irregular, and casual partners. So we also go to vaccinations, and these have different acceptability and deferral periods for the different vaccines. The adult vaccines, not the children's vaccines, because of course children do not donate. So we look at yellow fever, which has been going on in and around the country. The person who has received yellow fever must take 4 weeks to ensure that they donate again. Then hepatitis B, hepatitis A we accept, and for hepatitis B, we don't accept until after 2 weeks. Then those ones who have taken immunoglobulins like hepatitis B immunoglobulin, we give them 1 year. Then the anti-D, we give them up to 6 months. And COVID-19, we are giving 1 week. Then for the rabies, we go up to 1 year. Then we also look at the medical, surgical, and the drug or medication history. So someone cannot donate if they have flu, they have sore throat, cold sore, stomach bug, or any other infection. They are not supposed to donate blood if they have been treated or they have symptoms of an infection in the last 2 weeks. If they have had dental extractions or treatments in the last 2 weeks, if they have a history of chronic illness like asthma, diabetes, or epilepsy, and so many others that we consider according to our selection criteria. We have also those who are under the doctor's care for serious injuries or illnesses. Someone might tell you that for me, I've been seeing a doctor for the last 1 year. So we usually don't allow such people to donate because they may not give you all the information that you need, which may be dangerous to our recipients, our blood recipients. So someone should have received blood someone who has received blood in the last 12 months, we also don't allow them to donate for fear of the possibility of transfusion transmissible infections. Still under who is eligible to donate, we should not take off blood from someone with a positive test of HIV or someone who do not, or some people who do not know their HIV status. We should not take off blood from someone who has had an STD in the past. Then we should not take off some blood from someone who has just taken antibiotics. We give a grace period of 14 days for such a person to donate. Then for aspirin, we also consider it because it inhibits platelet aggregation. And here we take up to 72 hours, and then we allow the person to donate. For anticoagulants, we also don't allow those people to donate because for fear of risk of bleeding. Then those on heart and cancer treatment, we also don't allow them to donate blood. Then pregnancy and breastfeeding. This is a bit controversial here in Uganda because some people say, for example, when someone is menstruating, the selection criteria for those countries or those other countries apart from Uganda, they usually allow those people to donate. But here we take up to 7 days, and recently we've revised our selection criteria and we are taking up to 3 days. If anyone is feeling fine, if they are not feeling fine, we can go up to the 7 days like before. So following pregnancy, the deferral period should last as many months as the duration of the pregnancy. That means nobody should donate blood when they are pregnant, nobody should donate blood when they are breastfeeding, and they should only donate blood 3 months after they have weaned off their babies. Then the travel, this one has come out recently here. And here, many countries have implemented the policy to defer blood donors with a travel history. Here we look at areas where mosquito-borne infections are endemic, like malaria, dengue, Zika virus, Ebola, chikungunya. So here what we usually do, we restrict those ones from places that have gotten Ebola, chikungunya. But for malaria, we leave it because we are highly endemic. So we usually consider that. But during our QCs, we usually look out for certain units of blood and then do the CQ to see whether some units of blood have malaria in it. There is a note there, the National Donor Selection Guidelines has more eligibility criteria. That means there is more that we can ask you during your donation experience. And these criteria are different in different countries and among different types of donations, just like what I've told you about the countries on the menstruation period and the breastfeeding. So what is your role in improving the donation experience as a donor if you've come as a donor, what is your role? Before and during blood donation, you get plenty of sleep. That is before the night. You plan to donate. You drink extra water, not alcoholic drinks before your donation. You eat a healthy meal, avoiding fatty acids. You check to see if any medication that you are taking or recently took would prevent you from donating, just like we've seen on the issue of aspirins and anticoagulants. You wear a t-shirt with sleeves that you can roll up above your elbow. You let us know if you have a preferred arm or particular vein that has been used successfully in the past to draw blood. This assists us to avoid unnecessary phlebotomies. So you relax, you listen to music, you can talk to other donors, and or read while you donate. You tell us what you want so that your donation experience is improved. After donation, you sit in the observation area where you rest and eat a light snack for 15 minutes, drink extra fluids. You keep the bandage on and dry for the next 5 hours. If you feel lightheaded, inform the staff and lie down with the feet up until the feeling passes. If bruising occurs, apply a cold pack to the area periodically during the first 24 hours. Still, if bleeding occurs after removing the bandage at home, you put pressure on the site and raise your arm until the bleeding stops. If it doesn't stop, please go to the nearest clinic and inform us. Avoid strenuous physical activity and heavy lifting for about 5 hours. If you are a swimmer, a gym person, you should do that after 48 hours. Consider adding iron-rich foods to your diet to replace the iron loss with blood donation. You contact the blood donor center or donation center or your healthcare provider if you, one, forgot to report any important health information to the blood donation center. Here we are looking out for the adverse reactions. The adverse reactions or the possibility of you having a transfusion transmissible infection that may be possible to control at that particular time. If you have signs and symptoms of an illness such as fever within several days after your blood donation or immediately after your donation, you should inform us so that we exclude that unit of blood that you've donated. If you're diagnosed with an illness within 48 hours after donating still, you inform us. So what are the screening tests that we do at blood bank or at UBTS? So UBTS uses the following technologies to ensure blood safety. These include molecular technology, whereby we use NAT, non-nucleic amplified testing. We use serology, and this is immunochemistry and immunohematology. So all our technologies are automated to minimize on the errors. So here the tests done are human immunodeficiency virus, whereby we do an HIV combo antibody antigen. Then for hepatitis B, hepatitis C, and Treponema pallidum, we do antibody testing. Then we also do ABO and rhesus factor grouping, weak D, high titer, and antibody screening. What are the available products in UBTS? At all our regional blood banks and collection centers, we have whole blood. We also have packed cells. Then at the platelets and the fresh frozen plasma and the cryoprecipitate and the fresh plasma are found at the regional blood banks only. Because of the storage issues at the collection site, the collection centers, we are unable to have some of those products. So that means if you need them, you can inform us in time so that they are delivered at the collection centers near you. So what is our location of the blood banks? According to the region, we have in the north, we have Gulu, Gulu has a collection center, which is Lira. I'll tell you why I've highlighted the red. Northwest, Arua. Arua has a collection center at Nebi. We have Mbali in the east, which has Sorota and Moro. Then in the west, we have Fort Portal. Southwest, we have Marara, which has Kawal and Bukunjiri. Then we have Nakasero. Nakasero has Mengo Hospital. It has Jinja, Hoima, and Masaka and Chitovu. So the ones highlighted in red, government has elevated them to regional blood banks. So construction is going on in Soroti and Hoima at the moment, but Lira is still pending. So we are yet to be there anytime soon. So how do we handle or manage blood and its products prior to transfusion? Blood units, first of all, must be stored at the appropriate temperatures. Failure to follow the correct storage requirements may result in decreased transfusion efficacy, potential harm to the patient, or the product being unsuitable for use, and then the product may be discarded. The common cause of transfusion reactions is the transfusion of an incorrect unit of blood that was intended for a different patient. And this often is due to mistakes when collecting blood from the blood banks. Therefore, unit identification is very critical here. So what are the storage temperatures, the shelf life or expiry of some of these products that we have at UBTS? For whole blood, according to our standards, the standards we subscribe to, that is Africa Society for Blood Transfusion, we have 1 up to 6 during storage, and then during transportation, 1 up to 10, and the shelf life is 35 days. For the packed cells, it is the same as whole blood. Then for the platelets, they should be stored between 20 to 24 degrees, that is room temperature, and then transported at the same temperature, and the shelf life is usually 5 days. The fresh frozen plasma is stored at -18 and below. That is ambient after we thaw it. Then we maintain it at frozen state. As we transport it, it should be frozen until where it reaches. Then the storage or the shelf life, it takes 1 year if it is stored at -18 to 25. Then if it is stored above 25, above -25 and below, at 25, -25 and below, it takes 2 years. The same applies to cryoprecipitate is stored at -18 and below, and then maintained frozen in a frozen state when it is being transported, and it takes 1 year. So how do we access blood for transfusion? So I have to take you back to our mission statement, whereby we provide sufficient and efficacious blood and blood components through voluntary donations for appropriate use in healthcare. So what do I mean by this? Here we deal with health facilities. And the health facilities, as mentioned there, we've already seen what we have. We have Health Center 1 up to Health Center 4, then general hospitals or district hospitals, regional referral hospitals, and the national referrals. So classification is dependent on the service provided and the catchment area that we intend to serve. So in such health facilities, in Health Center 4, that is where our transfusion services are provided and above. So all transfusing facilities are assessed by UBTS for their capability or capacity to transfuse. And these transfusion facilities should order blood in advance whenever possible from the regional blood and collection centers. The orders must be completed accurately according to need and presented with validated ice boxes, ice packs, and insulating material for packaging. So this is not our role as blood bank. You should come with your things and a temperature monitoring unit or thermometer. You provide the following: on the blood orders, the product and the number of units required, the reason for transfusion, the urgency for patients' requirements for transfusion, when and where the blood is required, and who will deliver or collect the blood. Ensure that the correct storage and blood products during transportation and in the clinical area is sufficient.
Next slide.
The next slide is not going. So after ordering, orders and the cold chain items are verified by our people, and then they give you blood according to the inventory that we have. You should urgently transport the blood to the hospital blood bank along with the delivery form. Then the units are inspected on arrival to the hospital blood bank for temperatures and abnormal appearances and stored at the hospital blood bank. You should enter this in the reception book and then store in the refrigerator. The teaching aid, maybe we shall see later. You should, as a clinician, you should assess the patient's clinical need for blood and when it is required. That is on the ward now. You inform the patient and relatives about the proposed transfusion treatment and record it in the patient's notes. You record the indications in the patient's notes. You select the blood product and quantity required. You use the ordering schedule to guide us, to guide the transfusion. You complete the blood request form accurately and legibly. Some doctors have a tendency of writing ineligible notes. So you're not able to read whatever they have written. So this form should be accurately and legibly filled. And the reason for transfusion should be given. If blood is needed urgently, you contact the blood bank by telephone, or you go there yourself and request for the blood urgently, and you show them the need. You obtain and correctly label the blood sample for compatibility testing, and then you send the request form and blood sample to the hospital blood bank. Don't know whether I still have time, but the laboratory performs the pre-transfusion blood grouping, antibody screening, compatibility testing, and then selects the compatible unit. Then delivery of blood products is by hospital blood bank and a collection by clinical staff. These are the nurses and probably the doctors on duty. Then blood should be stored in correct storage conditions, if not immediately required for transfusion. Then you check the identity on the patient, on the products, and the patient's documentation. This is very important to the clinicians at the ward to prevent the adverse reactions that doctor is going to talk about. You administer the blood product to the patient. Then you record in the patient's notes. You monitor the patient before, during, and on completion of the transfusion process. You record the completion of the process, the transfusion, identify and respond immediately to any adverse reaction, record any transfusion reactions in the patient's note. There is also a form that was given by blood bank to fill in the reactions. It is an HMI's form. I think I may not go through the summary of this because I've done it. Let me just talk about something else, because this is almost the same. So in conclusion, clinicians are our blood donor recruiters. Why do I say this? They promote our blood donor recruitment programs in the following ways. They should avoid practices that lead to the sale of blood. They should make orders in a timely manner to avoid hospital blood stockouts. They should communicate to the patients and relatives the proposed transfusion treatment and how blood is availed at no cost. They should avoid holding blood units, not to cross-match blood products that are in, I don't see that, sorry. So they shouldn't cross-match the products that are not in need for patients who do not need them. They should avoid sending relatives to donate blood and availing proof of donation while nursing their loved ones. This is very important. It demoralizes our blood donors. For example, if the patient is a blood donor, they may not come back after they have healed. They should ensure that all patients and their tenants have a good transfusion experience. They should promote blood donation programs by conducting health talks on blood donation and organizing sessions for UBTS in the facilities and communities in which they live. I got to know Dr. Aggrey through a program that he organized somewhere along Entebbe Road. That was my first time of meeting him. And there he was, a doctor organizing, and we got a lot of blood, over 100 units, I remember. So they should donate blood during their offs or leave. They should also formulate or functionalize hospital blood transfusion committees, and the functions are there. They monitor safety, adequacy, and reliability of the supply of blood and blood products. My time is up. They establish systems and procedures for effective clinical transfusion practice. They coordinate education and training of all clinical and blood bank staff involved in the transfusion process. They monitor the usage of blood and blood products in the hospital. They review incidents of severe adverse effects or reactions. They review related issues such as availability of lab support and effectiveness of public health programs that are required for effective prevention and treatment of anemia and blood loss. So that is why they should be advocacy teams. Thank you for your attendance. I have a reminder there. We are organizing, or we are preparing for the Africa Society for Blood Transfusion Congress, which will take place between 4th and 7th of March 2024. It is a mistake there in Kampala. So you'll be able to connect with the world experts in blood transfusion medicine. Dr. Aggrey is our co-chair on this important congress. Thank you very much.
Thank you so much, Sarah, for debarking your presentation. I'm sure we've given you less time, but we are sorry. We don't want to congest our audience with too much, they may start running away. So, Sarah, very quickly, is there a possibility that blood is exported to other countries? No.
Yes.
Dr. Aggrey says no.
Yes, but now it is a no for now. But with time, we shall be probably taking out what we don't need, what we've been pouring.
Okay.
What we've been pouring, we are liaising with one of the companies in South Africa, and hopefully we shall be giving them our plasma that we discard for them to produce certain factors that we have. Dr. Aggrey is aware, but
Okay, thank you so much.
He's a pediatrician.
I appreciate your expertise. And there was someone who asked on the forum that how do we differentiate between anaphylaxis from status epilepticus? And I think the response was shared you should have seen the response. Definitely anaphylaxis is, it can be disseminated to involve any system, yet status epilepticus is normally limited to the respiratory tract. And another person asked, how do you manage bronchospasms? They were asking Joshua how he did, and that response has also been shared. So very quickly, let's ask our expert in transfusion to discuss for us the transfusion reactions, whether chronic or acute. I don't know why he chose to discuss only acute ones. Over to you,
It's a big topic.
Over to you, Dr. Dhabangi, for your input to today's presentation.
Yeah, thank you.
Great.
Mr. Moderator and the audience, thank you for keeping up. So my talk to you is going to be very brief, and I'm here to tell you about acute transfusion reactions. Now, overall, transfusion reactions can be really categorized in many ways. They may be acute or delayed. Sometimes Sarah's been talking about infectious. They can also be infectious, non-infectious, immunological, non-immunological. But today we shall restrict our talk to the acute transfusion reaction. This is just the outline of my talk. I'll just give a few definitions, how to recognize a transfusion reaction, the burden, and I will highlight the common acute transfusion reactions. Can I control my slides?
Yeah, you can.
Yeah. So, which way? Okay. So in terms of summary, I want to, for the audience, not forget this. So if you want to run away before the end of my talk, in summary, suspect that potentially this is a suspected acute transfusion reaction. If during or after transfusion, there are some unexpected changes in the vitals or development of new symptoms until proved otherwise. And then the other take-home message is that what do you do if you suspect your patient is experiencing an acute transfusion reaction? You temporarily or permanently, but in the immediate effect, you temporarily stop the transfusion, evaluate your patient, do vitals, take the vitals, the heart rate, pulse rate, BP, and SpO2, do a clinical check, because like Sarah mentioned, there could have been an error done in the laboratory leading to transfusion of an incompatible blood product. And then maintain IV access. And Harry was talking about the ABC, you know. If it is really life-threatening, ABC will save the day. And then call for help. If you can do this, and if you can remember this, then you know what to do should you encounter an acute transfusion reaction. So what is an acute transfusion reaction? So by definition, it's a transfusion-related adverse event occurring during or a few hours after transfusion. And we restrict the definition for acute transfusion reaction within 24 hours. So anything that occurs after 24 hours then will be a delayed transfusion reaction. And when you suspect, like I'll mention this again, any disturbances in the patient clinical situation, especially the vitals, consider it to be an acute transfusion reaction until proved otherwise. I'm not controlling my slides. Can I? Okay. And so how do you recognize a transfusion reaction? The most important approach is to monitor the transfusion. This is the best and safest way. And on the right are the gadgets that we normally use in an emergency setting. Check the vitals, the 5 vital signs that we know, but also the onset of new symptoms. This is the diagnostic criteria for a transfusion reaction. And again, I will say this again, the rule of thumb is any unexpected change in the vitals is a possible ATR until proved otherwise. And like we said, the symptoms can be anything, you know, from fevers, rigor, shortness of breath, and we shall go through this kind of picture. The vitals, this is just the approach that we actually advocate. Take a temperature, pulse rate, respiratory rate, BP, SpO2, and sometimes urine parameters. But we typically do this prior to the beginning of the transfusion, within 15 minutes into the transfusion, an hour into the transfusion, and at the end. And how common are transfusion reactions? There was a study done by one of our residents, he's now a senior colleague, and in Mulago, and overall, about 9% of transfusions may actually be associated with an adverse event following transfusion, and that is not small. The majority in that particular study with the febrile non-hemolytic transfusion reactions. Here is a table that characterized those events. The majority, again, in this study were the febrile adverse events, but a couple of others, like the allergic transfusion reactions, were common. There were 3 tackles, including a death. So the point I want to highlight is that acute transfusion reactions are not rare in our setting. How do they present? I like this approach that generally they present in 3 domains. They tend to be characterized with fever, so we talk about the febrile domain, or they tend to be characterized with rashes or with dyspnea. However, the symptoms may cut across the 3 domains, but typically they tend to fall in one of the domains, but it can cross boundaries, and beware that you can get a mixture. In terms of presentation, so if a patient presents with fever as the presenting symptoms following or during transfusion, then your differential diagnosis may either be bacterial contamination, it could be an acute hemolytic transfusion reaction, or a febrile non-hemolytic. On the contrary, if it is a rash or a symptoms in the rash domain, this could be either a minor allergic or the severe allergic, including anaphylaxis. The dyspneic domain are either taco or trally, and so on and so forth. So here is a summary of when you get a symptom, what do you suspect? I will maybe share this particular slide. The others, there is a resource that I'm going to share. So let's start with the febrile or fever domain. So by definition, think about a transfusion reaction related to fever if there is an increment by more than 1 from baseline, or temperature reaching up to 38. So that's what characterizes or defines a febrile related transfusion reaction. However, don't forget, it is either a fever, an incremented temperature, or a cytokine provoked equivalent. For example, if a patient gets a rigor, so a rigor is a cytokine provoked equivalent of a fever. So if the patient gets only a rigor, don't say, oh, this is not a febrile transfusion related event. So I have some cases, and I would want you to participate. So here is a 28-year-old woman with CA breast, had mastectomy 5 days ago, HB is 4, and so requires a transfusion. Transfusion started around midday, and 1 hour and 30 minutes into the transfusion, the patient is unwell. He has chills, rigors, nausea, headache, and so you are the attending nurse, you are called in to assess this patient. We said the best way to recognize the transfusion is take vitals. So in this case, they were the pre-transfusion vitals and the vitals at around the time when a transfusion reaction was suspected. So if you look at the panel on the middle column and the column on the right. So look at this, and you are going to respond to the next question. So of course, we indicated to you that the immediate action is stop the transfusion. So I'm going to the next slide, but remember the change. So what is going on here? The vital changes, the changes in the vital signs. So I want you to give me your opinion. What do you think is the most likely transfusion reaction? Punch it in the chat, and we shall see a few responses. What do you think?
Audience, very quickly read through and give us your mind. What is the most likely transfusion reaction? A is acute hemolytic transfusion reaction. B, minor allergic transfusion reaction. C, febrile non-hemolytic transfusion reaction. D, sepsis from her surgical wound.
Okay, got it. So the majority of the responses are pointing to a febrile non-hemolytic transfusion reaction. I agree.
Sure.
So what are febrile non-hemolytic transfusion reactions? These are quite common. I'm sorry about that. My slides are moving faster than me. Oh, can you go back? Okay, so they are one of the most common encountered acute transfusion reactions. It's a bit slow, okay, yeah. So about 1 in 100, you know. What is the cause? This is actually a benign fever. It's an inflammatory response. Cytokines accumulate when blood is stored. Sarah was talking about how blood is kept in the refrigerator. So once these are biologicals, once they are being kept in under refrigeration, some cytokines accumulate in there. And once you infuse this blood, they provoke That's what characterizes febrile non-hemolytic. And so I've talked about the definition. There should be a temperature rise more than 1 degree, and it is unrelated to hemolysis. So in this particular event, there is no hemolysis of the red blood cells. And that's why the term is termed as febrile non-hemolytic. The symptoms are really mild and characterized by fever with typically no other issues. The management, typically we stop the transfusion temporarily, do the vitals as we have seen in that panel, do a clinical check. You want to be sure that this is not a case where an incompatible blood product has been transfused. And you administer paracetamol or any antipyretic. And typically the approach is that overall the patient remains hemodynamically stable. And we tend to favor the approach of resuming the transfusion. So once the patient is hemodynamically stable, you administer an antipyretic, be comfortable to resume the transfusion slowly but cautiously. And this is the best approach. If things continue to deteriorate, you may have to suspend completely. In terms of prevention, we don't have a lot to do, but in other high-income countries, they do filtration of leukocytes. And once you remove these leukocytes, we don't tend to see a lot of febrile non-hemolytic transfusion reactions. So I will skip to the next type of transfusion reaction, the acute hemolytic. Because here, you transfuse an ABO incompatible blood product. Typically, it's a clinical error or a human error, where maybe blood was drawn from the wrong participant and an error was done in the laboratory, and so a patient whose blood group O is infused with blood group B, for example. It is common in some settings, rare in others. I cannot tell you how common it is in this country, because that particular study that was done by Weiser did not highlight this as common, but in other settings, maybe one in 6,000. The mechanism, you are aware about the natural recurring antibody. So these ones are the ones that will react with the transfused red blood cells. And you get hemolysis of the transfused red blood cells. There is activation of complement, and the situation is very bad. And again, hemolysis both intravascular and extravascular, and it can be fatal. And in terms of management, I will rush to management. You want to stop the transfusion, and if you suspect it's an acute hemolytic transfusion, you are not going to restart this transfusion. Because typically here the patient is hemodynamically unstable. If you do a clinical check, you most likely are going to find that would have been an error. The patient who was blood group B was given A. Inform the blood bank, retype the blood, and in terms of treatment, it's going to be supportive treatment most of the time. So you are going to transfer that patient to the ICU, IV fluids, ensure there is good urine output because they tend to really go into acute renal failure, give oxygen. If their BP is dropping, give a vasopressor and you'll save the day. Prevention, just be careful, avoid human error. I will skip this particular one in the interest of time, and I will go to another transfusion reaction. So I have a case here. So before I go into another transfusion reaction, I have a case, a 31-year-old woman with a plastic anemia admitted with a hemoglobin of 4.7. The doctor orders a blood bag, and it started 1 hour into the transfusion. The patient has itching and a rash, just involving the upper and the lower limbs. So you're according to evaluate the patient, and here is the vital panel. So look at it. Again, you stop the transfusion as the first thing to do. And I'm moving to the next slide. Look at the temperature changes, the BP, respiratory, and the change in the SpO2. And I have a few MCQs here. Again, punch in the chat box what you think this particular transfusion reaction could be. Okay, so the majority of you are already favoring that this could be a minor allergic transfusion reactions. I agree. So what are these? So they typically present as a type 1 hypersensitivity reaction. Dr. Rari has indicated this. It is mediated by histamine largely. So it is basically an allergic reaction to uninfused allergen. So an allergen is maybe the blood bag, a protein that is being infused, and maybe the patient already has IgE antibodies, and so it is an IgE antibody allergen reaction, and it is a type 1 hypersensitivity reaction. In terms of presentation, so they are quite common. In our setting, it's almost the second commonest after febrile non-hemolytic transfusion reactions. They typically present with just rashes, some erythema and itching. Typically tends to be mild, involving less than 2/3 of the body surface area. If you see more than that body involvement, then think about maybe this could be a severe one. Again, typically, the patient remains hemodynamically stable. Again, if the patient's hemodynamic state is unstable, suspect a severe allergic transfusion reaction. The management stop the transfusion, but temporarily. Once you do the vitals and you know the patient is hemodynamically stable, a clinical check is okay, but administer an antihistamine, including oral, like ceftriaxone or loratadine. And again, in this case, you are comfortable to restart the infusion. Cautious. We cannot do much to prevent because the donors in our setting, in some countries, almost 20% of the donors already, people have got IgE, so there's nothing much you can do. But if a patient has recurrences of this, you can pre-medicate them. The severe allergic transfusion reactions. So, I don't have a case here, but, oops. Okay, sorry about that. So the severe allergic ones, they too are type 1 hypersensitivity reaction, but their presentation is more life-threatening, more severe. The mechanisms are a little bit diverse. The majority tend to be IgA deficient recipients. So the patient is IgA deficient and maybe has got an IgA antibodies. But in some cases, just an exaggeration of what we have already seen for the minor allergic. So maybe it's just IgE that tends to be an over-exaggeration. And some rare cases could even be deficiencies in haptoglobin. The presentation, again, typically within minutes. Again, Dr. Rada has indicated, within minutes, it tends to present with a generalized rash, but on top of the rash, you get an accompaniment of something more than just a rash. So the severe ones, including the transfusion-associated anaphylaxis, it is way beyond the rash. You tend to get systemic involvement, CNS, GI, CVS, and even respiratory compromise. The management, of course, you want to stop the transfusion, take the vitals, and the most important thing is going to be to resuscitate, like the other patient who got anaphylaxis from a medication. This could also be from a blood transfusion. You want to resuscitate, and that's not going to save the day. The role of steroids, yes, you have to give epinephrine, like we have seen, antihistamine. And I will finalize this with the respiratory complications with a case. Here is a 27-year-old woman had an abortion a week ago, and prior to coming to Kawempe Hospital, she was already transfused with 2 units. So when they arrived in Kawempe, the HB was 5.6, and again 2 more units were given. And here is a summary of the vitals. As you can see, pre and post transfusion, the patient was feeling generally okay, and it was good. However, 3 hours after the end of the transfusion, the patient developed shortness of breath with cough, difficulty in breathing, vomiting, and the patient, the intern at that time, it was already in the middle of the night. In the HDU, gave some IV fluids, connected on oxygen, gave hydrocortisone. And the vitals are there, very, very scary, SpO2 70, and the patient was breathing away. So what is your take on this? Responses, please. Okay, so here is the text. I have a mixture of taco and trali. So the majority, I think, are saying D, trali. Oh, I have a B, that this could be an anaphylactic reaction. Almost go back. Anaphylactic reaction, by definition, there should be a skin involvement and a systemic involvement. As you have seen there was no skin involvement. So please, the people are thinking about B. I'm sorry, it is not B. So I think, oh, there's even an A, that is an acute hemolytic. Again, we have said the acute hemolytic transfusion typically present with fever. They are in the febrile domain. And then, you know, the hemolysis, evidence of hemolysis. There can also be some difficulty in breathing, but I don't think this is an acute hemolytic transfusion reaction. But yes, it could be. But until I do the hemolytic markers, I'm not sure whether this is an acute hemolytic. Anyway, this was TACO. So what is TACO? Transfusion-related circulatory overload is actually cardiogenic pulmonary edema following transfusion. There is fluid overload and capillary leakage in the pulmonary interstitial space. Usually there is a typical underlying maybe cardiac disease or renal disease, but typically there is also the risk that the patient was in a positive water balance pre-transfusion and then is given too much blood, or the infusion is rapid, one of the above. And so the patient presents with tachycardia, tachypnea, dyspnea, cyanosis, as you have seen. It is very common, up to 5%, and it can be very fatal. The patients at risk, again, I've highlighted that particular one, but the presentation and the categorization, the WHO and the International Society for Blood Transfusion has made this classification very clear. And the references there are very clear. I can read about that. X-ray findings are very typical, showing evidence of what? Of fluid overload in the lungs. And the management, you want to stop the transfusion. Again, do your vitals. A diuretic, intravenous diuretic could save the day, and other supportive treatment. I must say that, yes, it could be trali, and the separation between trali and TACO can be very challenging, but TACO is more common than trali. Think about TACO more than trali. Actually, trali is the next one, is a bit rare, like 1 in 10,000, and it's an immunological reaction, non-cardiogenic. Yes, there is pulmonary edema, but non-cardiogenic. It can occur a little bit faster, within 6 hours, but it's not as common as TACO. The mechanism, again, has been well characterized, and people favor to describe this in 2 ways. There is the first hit, where maybe there is some biological irritation resulting in some inflammation and activation of the neutrophils in the lung, and then when you infuse the blood product that may have leukocyte antibodies, especially the anti-HLA, that is the second hit, and then you get an antibody-antigen reaction. Again, the antibodies you are talking about are leukocyte antibodies. And the mechanism is illustrated in that chart, and the treatment, of course, is going to be supportive treatment. There is no specific treatment. And the criteria is very clear. Our time is well spent. The supportive treatment, you're going to give oxygen. There's no specific treatment. You can try steroids, but they tend not to help. You also can try diuretic typically, but they also offer no benefit. But the patient overall, within a few days, they are okay. And then I think I will conclude this in the interest of time. So in conclusion, acute transfusion reactions are very common in our setting. The best way to recognize them is by monitoring transfusion. And as a nation, we need to do more in terms of hemovigilance. Other countries like the UK have a national hemovigilance system. And in doing so, we can improve. Thank you.
Wow, thank you so much, our expert. I am feeling I am picking a lot from you by assimilation and association. And colleagues, transfusion is a do or do not. There is no room for making mistakes. So the reason for transfusion has to be extremely very clear. And it's actually it's one of the decisions that are very hard to make. And once you choose to go transfusion way, please be very sure you have the resources to ensure you monitor the patient up to the end of the exercise. You never know when an accident will happen. I take anaphylactic reactions to be accidents. You never know whether you are at 120, it will happen. Whether you are riding at 20 kilometers per hour speed, it will happen. So once you choose to transfuse, please be very sure. So it should not be a placebo thing to do. And the comment of they are not rare in Uganda, yes, this is very true. Maybe somebody should run a cross-sectional survey. It's because everyone wants to transfuse. You can even see someone in Health Center 3 wanting to transfuse. And yet a Health Center 3 will not be in a radius of 10 kilometers in most instances. So it shouldn't be transfusion for fun. This is a product that is a live, it's actually a live product. And we want to ensure that colleagues take it very, very serious. Once you choose, it should not be everyone actually to choose. There is a concern of someone saying what happens when somebody fails to get compatible blood, at what HB level. This will be the most unfortunate thing to find. What will be the cause of the need, the indication for transfusion? Definitely, if there is hemorrhage, the management will be conservative until God prevails over. And these are the most common cases that will possibly pass on. So when you check into the question and answer session, most of the concerns as you are posting are being addressed and taken care of. But should there be any specific questions to Dr. Dhabangi's presentation, please bring them on board by putting up your hand or writing in the chat. The CPD link should not be an issue. Why are you coercing the team here to share the CPD link? You are putting us on tension to share the CPD link. It will come. We can even email it. Or next time you are attending, you can say, oh, so those results I didn't get. But nonetheless, we are about to conclude. So we expect to share both the CPD link and the post test. This has been a very, very, very well, and I think it's timely. It's timely that we get it. And maybe from the pre and post test, if people do not get the basics, we can even record this presentation in the near future. And so far the attendance is 3937. I last saw when they were 391. So people are starting to drop off. Please keep on as we discuss a few of the concerns. There's a hand raised. There is a hand from, yes, please unmute and talk. This hand belongs to
Dennis. Is it Dennis?
Yes, Dennis.
Hello?
Yes, please.
Good afternoon, members.
Good afternoon.
Dennis Chen from Acute Hospital. And my question, yes, my question concerns about FFP, which is kept at the -18 Celsius. I'm wondering how this temperature is maintained on wards we are transfusing to patients. Won't it be also the products they are changed? Then another one. Is it good to warm blood before we transfuse to our patients? Thank you.
Then thank you. I will answer your questions very fast. So frozen plasma is frozen for the reasons that we want to preserve the quality of the product. It is rich in factor 8, factor 9, fibrinogen, and others, von Willebrand inclusive. Now, if you want to use it, the first thing is you thaw it. Thawing it, you bring it room temperature. After thawing it, you can even put it in the fridge if you can't infuse it immediately. So you can thaw it and keep it in the fridge even for the next 24 hours, even for the next 2 days.
but not going beyond 5 days. So, yes, it has to be thawed. And once thawed, you must make good use of it within a few days, not going beyond 5 days. Warming of blood is not necessary. Blood, we are referring to either whole blood or red cell concentrates. So once you pick these two products from the refrigerator, you typically just hang it up. And you remember your counter current flow in biology. By the time it really flows through that tubing to the patient, it's at a good temperature. So there is no indication for warming blood. There are a few cases in emergency medicine, and especially when you are infusing large volumes, we call it, massive transfusion. So in the setting of massive transfusion, where you are giving a lot of fluids, we tend to warm all the fluids, including normal saline. Again, in massive hemorrhage, the risk of, coagulopathy of, hypothermia, it actually completely kills everything. So hypothermia is a risk in massive hemorrhage setting and resuscitation. So for that case, under those circumstances, yes, you can warm the fluids, including blood. But outside of resuscitation, in a setting of massive hemorrhage, please do not warm blood.
Okay, thank you so much. But could you tell us the drip rate for blood transfusion?
So the ideal would be to infuse whole blood or red cells within 2 hours, maximum not exceeding 4 hours. In terms of rate, yes. Best regulated with a device such as an infusion pump. However, you can also manually regulate this. We know how many drops may be in a meal, and so good nurses can actually do this very well. And so if you don't have an infusion pump, you can actually regulate this manually. But don't run it very fast, because you can actually put the patient at risk of tackle.
Okay, thank you so much. But as I earlier mentioned, do you still consider the other instance, like we are talking of mass transfusion?
The definition of massive transfusion is even vague. And so in that case, it is very rare. Typically, they say you are infusing or replacing like more than 25%, 50% of your total blood volume. Now, in that case, that is really rare. We don't even have enough blood that you can actually push in 10 mils of blood.
For Russia.
So massive resuscitation hemorrhage is really very critical. The people in emergency medicine really need to do better. We actually would not have enough product to really fill that criteria.
Okay, Dr. Dorian, please come here for people to see you. Just in a second. Dr. Harry? Yes. Please come forward. Sorry, I forgot to tell you that I'm a major in the forces, so sometimes I use commands.
We understand.
Now you understand. So in 30 seconds, I want us to discharge Dr. Larry as a senior trainer who has been so beneficial to the audience and the people here. So Ugandans are very proud of him. Kindly discharge him in a very well elaborate sentence, and the team around kindly reward him with a flight item that is not going to be rejected at the airport due to the cargo. Please go on and discharge him.
So hello to the team online. Thank you for logging in. Thank you to the team here that has taken part in this echo session. Dr. Harry, we want to thank you so much on behalf of the ECHO project under the Ministry of Health, SEED Global and Emergency Care Society. We thank you for the work you've been doing. You have been a mentor, you have been a teacher, you have been a colleague, and I think that you will agree with me that Dr. Harry has really put in a lot of effort to ensure that these ECHO sessions are done, and they're done excellently well. We don't take it for granted. The team online, I'm sure, has benefited from your wisdom, and we shall carry this on in our practice. We want to hand over this token of appreciation on behalf of the whole team. As you travel back to overseas and back home, this will remind you that Uganda is also still your home. And we thank you so much, Dr. Harry.
Thank you. It's such a pleasure.
Thank you.
Okay, and what to the audience? We still have about 300 participants, and to us.
Okay.
Yes.
Thank you. It's been my pleasure. Oh, wow.
So colleagues, we are happy to have had a senior practitioner in emergency medicine, and to the teams in Banana and Makerere, you must have experienced him. We want to thank you so much for today's input. The CPD link has been shared, and please, if there are any sessions that you have attended and the CPD points have not been accredited for nurses and midwives, I know for nurses and midwives it's been a challenge to share, but overall, we are saying if you have proof that you have ever attended, and we can track this, that's the beauty of technology. They will award your points, but share the CPD, what do we call it? No, share your registration number where the points can be loaded. There is a question Dr. Dhabangi has to answer very quickly, and please take it on so fast so that we conclude.
There is, by the way, feel free to ask any more questions about transfusion. It's my area of expertise. So one member has really raised an important question, that they encountered a patient who was blood group O RHD negative, and the patient's hemoglobin was 5, and they did not have O negative blood. And so the question is, what would be the best management for this patient? So I must say the following, and please mark my words. Number one, in our population, about 4% of us are RHD negative, and about half of us are all blood. So if you multiply that, it makes that about 2% of our population in Uganda are maybe RH negative. So it is not very, very common. And that explains why sometimes RH or neg, or we just call it O neg blood, may be rare. So if somebody is O neg, needs to be transfused with O neg, if you do not have O neg blood, what can you do? So you can find it where it can be found. And so you can call the Nakasero blood bank or the nearest regional blood bank. They tend to keep these as emergencies. So don't assume that it is not available without making an effort. So you call, if you are within Kampala, call Nakasero, there is always an O-neg blood somewhere. In Mbarara, if you are in the area, call the Mbarara Regional Blood Bank, they will always have an O-neg. Now, should you fail to catch one, that's the next approach. What should you do? The best management plan. Number one, you must save this life. How? If you transfuse an O positive blood to an O neg patient, the risk is that you can actually sensitize this patient, alloimmunize, so they may make an anti-D. What is the risk? About 20 to 30% of the time, if you transfuse an O positive, or we can say D positive to the D negative patient, so 30% on average, in an emergency setting. Now, if it is not an emergency setting, for example, if you're voluntary, patient, just transfuse with blood, it can even go up to 60%, the risk that you can actually be alloimmunized. But in an emergency setting, about 30%. Again, it is even much lower, for example, in cancer patients because of their immune system. So it can even be up to like 5%. So the point here is that, yes, there is a risk up to 30% of making an antibody. But in this setting, you are concerned about saving the life. And please note that when you transfuse O positive to O neg, in that time, nothing will happen. So they are not going to encounter a transfusion reaction unless if this patient was sensitized previously. But if this patient had not been transfused previously and does not have the antibody yet, there will be no event on that occasion, except for the sensitizing event. What do we mean by sensitizing event? They will make an antibody, and they will move with this antibody without causing any problem. The problem will arise when they require another transfusion next time. So please go ahead and first of all, tell the patient the situation you are in. And once they know, it is agreeable to sensitize them and save their lives.
Yeah, emergencies are like that. I want to tell people that for us, in the forces, it's good to take a decision.
Yeah.
Whether bad or good. But a bad decision well executed is better than a well thought of decision delayed. So in patient care, surely, make precision. That's the most important.
Yeah.
And consult the resources available in consultation with the patient, agree to consent for anything inevitable that you can't do without. So,
and actually, studies have shown that if you talk to the patient, they are agreeable to have their life saved compared to not risking them being sensitized. Again, don't give hydrocortisone because it will not stop the sensitizing event. The process, it's similar to how you get a vaccine. If I give you a COVID jab, will you make antibodies? Yes. How long does it take? It's the same process. You know, antigen presenting cells will come on the way, then memory cells, and then finally make antibodies. So it will not stop. So giving hydrocortisone does not help. But the best thing is that maybe you can follow up a month later and do an antibody screen for this patient to see whether they have made an antibody or not.
Oh, thank you so much. So I want us to say that today's session and lesson should come to an end. We're supposed to have taken 2 hours of our session, but we appreciate that we couldn't again cut it off and cut it short. We will request the general audience to assess the session for today and attempt is the post test still on or it's on or done? Okay, so they can check within their locations. And as of now, I want to hand over back to Balikaziwa Thomas to take us through the screenshot session. Some of us are not good for pictures. We even fear to take them, but kindly take pictures of whoever you feel you should take. And since I'm also available, I can say whether good or bad, please take me.
Thank you so much, moderator. I hope I am audible enough. The session has been one of the very, very well-attended sessions and very interesting, very informative because the subject of blood transfusion, and then allergic reactions and anaphylaxis is a common thing that can easily be mismanaged, if at all even recognized. So at this moment, I would love to appreciate our experts. Dr. Harry, thank you so much for your time and for your service during the eco sessions. We are proud of you. We are happy that you have been part of us. We've learned a lot from you. I'm sure even our online participants have learned a lot from you. Our experts, we appreciate you so much. And our participants, you are the best because without you, we cannot do eco sessions and we shall not strive for any improvement in emergency care. We have run some pre and post tests. We are now sharing the results. I hope we can see. Maybe we could take us through some of the questions which were not answered as expected or caused confusion. Question 1, it was saying 7-year-old child with severe anemia is admitted to a pediatric ward receiving blood. 1 hour, 30 minutes into the transfusion, she develops itching and skin rash involving the upper limbs and trunk. She's otherwise stable, no fever, no bad signs. You suspect acute transfusion reaction. What is the most likely one?
Yeah, so why is it not an acute, so the correct answer is a minor allergic transfusion reaction. Again, it's very clear the child only had a rash. It was involving only a particular portion of the body, not going beyond 2/3. And that is the classical presentation of minor allergic. So the question is, why go up? Why is it not an acute hemolytic? Typically there will be hemolysis and fever. This child did not have any other symptom. Even for acute hemolytic, remember the cause is actually an incompatible blood component transfused. The hemodynamic situation is going to be very bad. It is also not an anaphylactic transfusion-related event. Again, we have learned today about anaphylaxis. Yes, there is fever, it tends rather rash, it tends to be generalized, but the systemic involvement is the hallmark of anaphylaxis. So don't just assume that any rash is anaphylaxis. Please, whether it is from a medication or from a transfusion. Anaphylaxis, I will say again, rash, typically generalized, together with systemic involvement. And so that's what excludes that.
Thank you so much, Dr. Dhabangi, and I hope going forward, all of us, we can recognize the different reactions and how to manage them. So also question 2, we had some confusion between answer 1 and answer 3, so, or even answer 4, so people were spread among those options. It says a 72-year-old man with type 2 diabetes, hypertension, and CKD has received 2 units of whole blood. Shortly after, he develops difficulty in breathing with a rate from 24 rates per minute to 46. He has cough and really looks unwell. As the attending nurse, your most appropriate immediate action points should be?
Yeah, so I did this deliberately, but the first approach is stop the transfusion, take vitals. But before I get to the other subsequent one, what is your most likely diagnosis here? Any volunteer?
Anyone who can unmute and tell us a diagnosis here, what you think?
Someone there? Well, this is an elderly patient, 72. He has CKD. So that's a risk factor for what we have discussed today. And then he receives 2 bags of blood and immediately he gets into dyspnea. What's the most likely diagnosis here? Taco, typical. You have taco. This patient has got 2 risk factors or 3. He's elderly, he has kidney disease. He also has asthmaticus. Yeah, diabetes. He has kidney disease and he receives 2 units at a go. Again, the approach is 1 unit at a time. So how do you manage taco? Stop the infusion, take vitals, and act accordingly. Oxygen may be required if the SpO2 is below, and give Lasix. So please don't give normal saline. You are going to worsen the hemodynamic situation. Yes. So A, B, C are completely wrong because of normal saline. And then aminophylline will not help here. And so that's why we are giving Lasix and oxygen. So the correct answer was stop oxygen, take vitals, give IV Lasix, and give oxygen. It was D.
You had pulmonary edema. Take that.
So it seems we had an error on our side. We didn't put the option of Lasix. So we apologize for that. But we are sure that you've learned from this section. What matters is to recognize the reaction and then you know how to act accordingly. Question 3, people also answered well. It says, a 38-year-old man develops severe itching and hives all over his body within a few minutes of starting to eat at a restaurant, and paramedics are called. His heart rate is 102, blood pressure is 85 out of 65. Which of the following signs and symptoms warrant urgent epinephrine administration?
Yes, and so it's really just the skin thing. The skin symptoms are not enough by itself, but the low blood pressure, so that's the C, circulation that is affected that would fit the criteria of anaphylaxis and require epinephrine.
As we are winding up, question 4, it says a 17-year-old boy hiking in a forest is hung on his left foot and within a minute has itching at the site. His condition worsens and he develops generalized hives, chest tightness and shortness of breath. He becomes unresponsive during transit to the emergency department and is cyanotic upon arrival. What immediate treatment is most appropriate?
So for this patient, it's anaphylaxis, full-blown anaphylaxis that is life-threatening. And epinephrine initially 1 to 1,000, 0.5 milliccc's is appropriate. If the patient ends up in cardiac arrest, then we would think that IV epinephrine would be appropriate. But at this point, there's nothing to indicate he's in cardiac arrest. So the correct answer is A.
Okay. Move to question 5.
So question 5 was answered well. It says the following are physical requirements that are used when selecting the blood donor except height. If you include height, most of us are short people maybe will not be donating blood. Then question 6, it says blood donations may be taken from individuals between the ages of. So the answer is between the ages of 17 to 65 years. So let us take note, and most of us participants will fall within that age bracket. So if we are well, we have no reason not to donate blood. Thank you so much. Let us take screenshots as we end this session, that we are happy that you have been able to stick on to the edge.
So we call it the end.
Yes, those who are able to put on your cameras, we can take screenshots. Anyone who wants to give us a final comment or even appreciate our panelists? I am seeing Cliff. Anyone, our participants, anyone who wants to appreciate our panelists? Unmute.
Dr. Businde Wargawa Amos from Ibanda. I want to thank our presenters and all you panelists for having educated us, especially in our work on anaphylaxis and also remaining us how to differentiate anaphylaxis from mild infections, especially blood transfusion. Thank you very much.
Thank you so much, Amos. We would want to wish the rest of you a happy weekend. Please spare time and find a donation center and donate blood. You never know who will need the blood, maybe you yourself. So do not stop yourself from donating. We have all that about blood donation. Have a very nice weekend. See you in 2 weeks. We are going to be doing a session on chest pain in adults, so we are going into the heart. So do not forget to log in 2 weeks. See you. Bye-bye.
Au revoir. Bye.